fantastic speakers today. I will say I'm personally biased as someone who does lung cancer, that I think, like Dr. Jane was saying, that lung cancer is probably the most exciting field in oncology, but there's a lot of exciting things going on in all the cancer research fields. I'm very excited to introduce Dr. Frank Weinberg, who's also an assistant professor at in the Division of Hematology and Oncology at UIC with us. He runs the lung cancer program as well as the thoracic tumor board program at UIC. He's also a part of the UIC Precision Oncology Tumor Board program, and we've got some more amazing members of our team here a part of that as well. He got his PhD in cancer biology at Northwestern, then his MD at UIC. He does research in biomarkers in the underrepresented high-risk lung cancer screening population. He's the PI and co-PI in multiple clinical trials here, and I'll brag for him, he's the highest enrolling clinical trialist at UIC. And so with that, I'll turn it over to Dr. Weinberg.
Thank you so much, Ryan. This is like, at first, I feel like I'm giving a TED talk today on lung cancer. So we'll go with this. And I'm excited because I get to talk about probably one of the most interesting areas of lung cancer research right now and trials, which is sort of the perioperative space. I know I'm saying we're talking about navigating neoadjuvant options, but that really, since October of last year, has become perioperative options. So here are my disclosures. Oh, am I going the wrong way? Here we go. The gray area. So I think, early stage lung cancer in general, especially what we're going to talk about today and focus on is resectable lung cancer, is sort of the gray area right now. What do we do in this space for patient care? So you'll see kind of how I'm approaching it. I don't think that there's any wrong or right way right now. There are FDA approvals, there are practice-changing studies that we're going to talk about, but I think people are still getting used to this very new treatment regimen, and learning how to treat these patients optimally is a big issue. So here's how I kind of approach the early stage lung cancer landscape. So just for completeness, obviously stage 1A disease, I'm not going to talk too much about because that's kind of, for the most part, understood to be either surgery or radiation if they're not surgical candidates, or if the patient prefers not to undergo surgery. We do have, and others have, adjuvant studies in this space with immunotherapy, for example. So obviously a plug for clinical trials, refer patients to us or other places that may have these studies. But for today, I'm going to focus basically over here in the stage 1B, 3A and B setting. And we'll talk about the staging and whatnot, what that includes for a lot of these studies. And more importantly, we're going to talk about resectability. So I think when you have a patient in this stage of disease with lung cancer, the first question that you have to ask is the patient's cancer surgically resectable? If it's not, then you're just going to go to sort of your algorithm for treating unresectable cancer, which we're not going to talk about today, but that includes chemoradiation and things like that. So let's focus on patients that we actually know are deemed surgically resectable. And how do we deem if a patient's surgically resectable? Well, I sure hope it's not me alone. It needs to be a multidisciplinary conversation with your surgeon, with your radiologist, with the medical oncologist. And when you have this discussion, then you can come to a consensus on whether or not a patient with this stage lung cancer is in fact resectable. So let's say, for intents and purposes for today, that we have a resectable patient. The next question is to understand whether or not the patient is a candidate for neoadjuvant therapy, okay? So if the answer to that is yes, then we're going to talk about my approach, which is to use perioperative chemoimmunotherapy, and we'll talk a little bit about why I think that's important. If the answer is no, for a variety of reasons, which we'll talk about later on, then we're going to talk about adjuvant immunotherapy after adjuvant chemotherapy. If they're not immunotherapy candidates, I think chemotherapy obviously still has a place in adjuvant treatment for lung cancer. And then now we're also getting at, targeted therapies and adjuvant targeted therapies that I'll end the talk with today, okay? All right, so I always ask myself how we get to a place in oncology. And I think about the history. Dr. Jane also had a history slide. I like history. I like to know why something is the way that it is in present tense. So I think we can say from a neoadjuvant setting, there were a whole number of trials that were seminal back in the mid-90s and then again kind of repeated in the early 2000s that kind of showed that specifically for patients with 3A disease who were resectable, the addition of neoadjuvant chemotherapy led to improvements in median overall survival. And that's really why for a long time in the NCCN guidelines, you can still see this. Chemotherapy is still listed as an option for neoadjuvant treatment of these very select stage 3A patients. So that's sort of how we got to this trial, which is, back in the late 2010s and early 2000s. This is a Checkmate 816 study. This is a study that looked at, again, newly diagnosed resectable stage 1, so that's tumors larger than 4 centimeters, to 3A non-small cell lung cancer. They were deemed, obviously, to be resectable up front, and then they were randomized to either receive chemoimmunotherapy with nivolumab as the agent in this study for up to 3 cycles versus chemotherapy for 3 cycles. They then were radiographically restaged, and then surgery was performed. They had the option of completing adjuvant chemo plus or minus radiation. About, I think, 40% of patients in this study received adjuvant chemotherapy. The primary endpoints, pathologic complete response and event-free survival, those are kind of the surrogates that are being used, as my breast colleagues, who I don't think are in the audience now, can kind of say. Those are kind of the surrogates that are used sort of for neoadjuvant treatment in general. So in the lung setting, it's the same sort of deal. And so what we find in terms of efficacy, if we look at the pathologic complete response rates in this Checkmate 816 study, significant improvement in pathologic complete responses with the chemoimmunotherapy that is using nivolumab versus chemotherapy alone. So that was really interesting. And anecdotally, I have had patients who I treated this way who've had complete responses. And then you're stuck with whether or not they should get surgery afterwards. They should. We're not to the rectal cancer point yet. You should absolutely, patients who get neoadjuvant lung cancer, I can say definitively for right now, surgery should be pursued even if you have a pathologic complete response at this point. So here's the event-free survival, also statistically significant. At 24 months, 82% of patients were still alive versus 70.6. So this is interesting, and it led to, in 2022, FDA approval of neoadjuvant chemoimmunotherapy for early stage non-small cell lung cancer. Most of us, I think, at the academic centers adopted this readily into our practice. So here we are. This is the neoadjuvant sort of landscape, right? And so you have this Checkmate 816, that's been approved, but you can see a whole host of other studies that included sometimes monotherapy, immunotherapy, or other studies that included chemotherapy with immunotherapy. All of these have not read out but yet completely, but a lot of them are showing similar results as the Checkmate 816. So what can we say from this? We can say that neoadjuvant treatment works, but what's the issue? We're oncologists, and we know that we're not, until we have everybody into remission, we're not satisfied, right? And so we know that there's a lot of patients, the majority of patients still recur even when you treat this way, right? And so we're not doing good enough. So what the oncologists do, they add, and they added adjuvant immunotherapy to the regimen in this study, Keynote 671. So this is perioperative treatment now. So we thought, hey, neoadjuvant treatment works with chemoimmunotherapy. What about doing chemoimmunotherapy, surgery, and then adding immunotherapy afterwards? Are we going to improve outcomes that way? And so this study, again, resectable stage 2, 3A, and 3B, that is 3B, that is N2 nodal involvement, randomized to receive either chemotherapy with immunotherapy, pembrolizumab being the agent in the 671 study, versus chemo placebo, up to 4 cycles, and then surgery. And then this was followed by pembrolizumab for up to 39 weeks, adjuvantly, or placebo, adjuvantly. And they looked at event-free survival and overall survival as their primary outcomes. And you can see here, very interestingly, event-free survival, positive, and pembrolizumab, overall survival, positive in the pembrolizumab group. And so this gained FDA approval in October of last year. That is approval for pembrolizumab with platinum doublet chemotherapy as neoadjuvant treatment, and then with continuation of single agent pembrolizumab as post-surgical adjuvant treatment for early stage disease. That's disease that is greater than 4 centimeters or node positive. There are also additional studies that have been kind of looking at the perioperative space. This is another study, but we're going to substitute nivolumab in for pembrolizumab in the NADIM-2 study. And we're also going to be more specific about what chemotherapy we're going to offer patients, which is carboplatin paclitaxel. And we're going to compare that. Again, these are more specific set of patients, stage 3A and 3B. We're going to compare the chemoimmunotherapy arm to just chemo alone. We're going to undergo surgery and then follow that with adjuvant treatment, nivolumab, for 6 months versus observation. And this also was a positive study. This is pathologic complete response. You can see an improvement in the chemoimmunotherapy arm as well as overall survival. It's not yet approved, obviously, in the perioperative setting. So let's just go through the host of studies that are being done now where they're just substituting, each company is sort of substituting their own PD-L1 into the perioperative setting. So you can think about these studies very much like the Keynote 671, only with whichever company is doing it, their specific agent. So this is the Aegean study. This is durvalumab substituted in for the pembrolizumab here. These are, again, patients who have stage 2A to 3B, that's N2 involvement, who were randomized to receive durvalumab plus platinum-based chemotherapy versus placebo chemotherapy, went for surgery, and then received up to a year of durvalumab versus placebo. Primary endpoints here, pathologic complete response and event-free survival. Again, a positive study. So event-free survival, 63 versus 52 at 2 years. Pathologic complete response, also positive, 17 versus 44.3% of patients. We have the Checkmate 77T trial, which is kind of like the NADIM-2 study, but a little bit more broader in terms of allowing folks to pick what chemotherapy regimen they use, and also it's a placebo-controlled trial. So again, this is resectable 2A to 3B disease, randomized to nivolumab chemotherapy versus placebo chemotherapy, up to 4 cycles. So a little bit different than the Checkmate 816, which was 3 cycles. You get a little bit more here if the patient tolerates it. And then surgery followed by nivolumab for up to 1 year, with the primary endpoint being event-free survival. And here as well, a positive study, 70% versus 50% at 18 months in terms of event-free survival, comparing the chemoimmunotherapy arm to the placebo chemotherapy arm. And then this is in its infancy. I haven't seen actually preliminary data on this, but I just want to make sure that I mention that atezolizumab is also being integrated into this space as well. So I would anticipate that this will also be a positive study, but I haven't seen any of the preliminary results on the Empower 030 study. So here we are. Here it's kind of a summary of perioperative treatment modalities. Obviously, the Keynote 617 is the one that's FDA approved right now. So it's the one that I'm integrating into care of patients who qualify. But you can see as we compare all the primary endpoints, similar across the board in terms of primary endpoints being positive with the addition of immunotherapy to chemotherapy and that addition of adjuvant immunotherapy. So this kind of argues that perioperative treatment maybe even works better than neoadjuvant treatment at this point. But I think the biggest issue, and we do this all the time in the oncology space, is we overtreat patients, right? I mean, that's what oncologists do. We overtreat patients because we don't know who should be actually getting the treatment. Who should actually be getting adjuvant immunotherapy? I don't know, but I sure don't want to miss anybody who could get or benefit from receiving adjuvant immunotherapy, right? So what do we need? We need better biomarker development in this space. We need better biomarker development in the neoadjuvant space. Do our lung cancer patients who obtain a pathologic complete response truly need any more surgery or treatment after that? And if they don't, who are the patients that we can be okay with not giving more treatment to, right? So we need better biomarker development in this space, certainly. All right. So the exceptions of patients who I consider for perioperative treatment, I talked about a little bit at the beginning, but certainly this hasn't been adopted fully across the board, right? So you're still going to have patients that come in who have already had surgery. Oftentimes they see the surgeon first. Sometimes the surgeon will just take them to surgery and that it is what it is. And then they see you afterwards, right? There are also going to be patients that aren't neoadjuvant treatment candidates. There are also patients who are not immunotherapy candidates. So I just want to make it very clear that I still think that certainly adjuvant chemotherapy has a place in the treatment of these early stage patients. You have a patient who comes in who's had surgery, who's not an immunotherapy candidate, you can still give them chemotherapy. Why? Because based on this LACE meta-analysis, which was a seminal paper that came out in the mid-2000s, we know that giving 4 cycles of platinum doublet to a patient after from stages 2 to 3 benefits them on the order of about 5%. But if you delve into subgroup analysis on this LACE meta-analysis, you'll realize that if the patient is a little bit more advanced locally, so your stage 2Bs or your 3As, you're looking at an improvement of closer to 10 to 20% in overall survival. So certainly chemotherapy has a role in the treatment of early stage lung cancer, especially for patients who have already had surgery, can't get immunotherapy, even if they have gotten are a candidate for immunotherapy. I think chemotherapy is still should still be considered in those settings. We'll talk about that in a second. All right, so you have a patient who already had surgery, comes in, and also maybe has been deemed not a neoadjuvant and/or hasn't been deemed a neoadjuvant treatment candidate. I think the first thing that I always do when I'm thinking about adjuvant studies now in the setting of immunotherapy, which we're going to talk about in a second, is I think about the PD-L1 status in these folks. So are they greater than or equal to 50%? Are they 1 to 49%? That has ramifications now in adjuvant treatment. Why? Because the Empower 010 study demonstrated a benefit of utilizing adjuvant immunotherapy, in this case atezolizumab, after 4 cycles of adjuvant chemotherapy. And so these are patients who were completely resected, stage 1B to 3A, receive up to 4 cycles of chemotherapy, And then were randomized to receive best supportive care or atezolizumab for up to a year. The primary endpoints were disease-free survival. And you can see here, this was a positive study, 60% versus 48.2% at 3-year analysis, improvement with disease-free survival in the patients that were treated with atezolizumab. But I'll just mention that I think what's interesting is when you look at subgroup analysis for PD-L1 status here, you can see that those patients that have greater than 50% PD-L1 expression, significant benefit here, probably driving the overall benefit that we see. So certainly here, I usually think of atezolizumab, incorporating that into the adjuvant setting when patients are PD-L1 positive and their PD-L1 is above or equal to 50%. This gained FDA approval, though, in 2021 for adjuvant treatment following resection and platinum-based chemotherapy in patients with stage 2 and 3A non-small cell lung cancer. All right, and then we have the KEYNOTE-091 study, or the PEARL study. So this was a similar study. Again, it was patients who underwent complete surgical resection, confirmed stage 1B to 3A patients, received adjuvant chemotherapy, and then were randomized to pembrolizumab for up to 1 year versus placebo. And here, there were endpoints, disease-free survival in the overall population, and then also disease-free survival in the greater than or equal to 50%. And this study was a bit surprising. Why? Because while it was positive, a positive study, 3 years out, disease-free survival, 58% versus 50% in patients who had received the pembrolizumab arm, the overexpressors, the PD-L1 overexpressors, those are greater than 50%, you see there wasn't a significant difference. This is like one of the first studies that we saw this, because usually up until this point, we had kind of thought that, pretty much you give immunotherapy to patients who express greater than or equal to 50% PD-L1 on their tumors, and they're going to do better compared to those with lower. But here, the issue was we actually saw that adjuvant treatment in the 1 to 49% population were better. There's a lot of different conjectures about why this might be, but suffice to say, if I have a patient within the 1 to 49%, I might go to pembrolizumab for treatment in the adjuvant setting if I were to need something. Again, this was FDA approved in 2023 following resection and platinum-based chemotherapy for stage 1B greater than 4 centimeters, 2 or 3A. I just want to point out this interesting, and these are low numbers, but they included patients with EGFR mutations here, and you can see they derived a benefit from immunotherapy. I don't know what that means, but it's a great segue to talk about testing. So I'll get on my soapbox, which a lot of you know in clinic, I go on soapboxes sometimes about testing, but I really think molecular testing is central to really all cancers at this day and age, but really in non-small cell lung cancer, comprehensive molecular testing needs to be sent, and not just on metastatic non-small cell lung cancer patients. We need to send it probably on our early patients as well. And we're doing that at UIC, but it's not yet fully understood around the country. Heck, it's not even understood that the metastatic non-small cell lung cancer patients need to get testing. Look at our rates. So from 2017 to 2019, when they tested just for 4 molecular biomarkers, and they assayed, they asked these docs on these practices, 69% of their patients were still not tested versus 31%. We've gotten maybe a little bit better from 2015 to 2020. We're maybe at 68% of patients being tested. We're not anywhere near where we need to be in the metastatic setting. And now I'm telling you that maybe we need to do this in the early stage setting. Yeah, I do. I do think that all patients with non-small cell lung cancer need to have comprehensive molecular testing, because it has treatment ramifications. Obviously, you saw just within the last year in the perioperative setting, we've had 3 approvals. So we're changing all the time, and I don't understand why a patient shouldn't have testing. There are now also guidelines, ASCO guidelines, NCCN guidelines that suggest that if you have a tumor that you have more than two or more molecular targets that are targetable with treatment, you should be sending comprehensive molecular testing. And it's not okay to just send single testing, in my opinion. Why? Because you use up tissue that could be used for comprehensive molecular testing, right? So you don't want to have to go back to the patient and say down the road, hey, we have no tissue left. We have to rebiopsy if you don't have to, right? And so I think it's important upfront just to send the comprehensive molecular testing. I'll also make a plug for testing your underrepresented minorities. My goodness, I mean, you look at Black patients, they're 20% less likely to receive comprehensive molecular testing than white patients. In my population, I see primarily underrepresented minorities. They deserve the same testing that our counterparts, the white majority, receive as well. So please, if there's a take home from this, test your patients and test all patients. I'll just say that, there's obviously argument for early stage testing because the PD-L1 level, which I told you is impacting how we utilize treatment decisions, and also EGFR, and soon probably to be an ALK indication as well in the early stage setting. So send molecular testing, please. All right, so why the targeted therapy? Because the ADORA trial, basically. Then this was a trial that looked at completely resected stage 1B and 2 and 3A non-small cell lung cancer, which they were without adjuvant chemotherapy. And they were stratified, about 60% of them received adjuvant chemotherapy, but then they were stratified or randomized to either receive osimertinib for 3 years versus placebo. And this was a very, very positive study with a hazard ratio that I don't think I've seen in any other lung cancer study. So very, very positive study. 5-year overall survival, also positive. This gained approval for osimertinib in the adjuvant therapy after tumor resection in patients with common EGFR mutations and non-small cell lung cancer in 2020. And then the Linus study, which is the one I was talking to you about, which basically is similar to the ADORA study, only substitute ALK fusion positive patients here. So these are resected stage 1B to 3A patients with ALK fusion positive non-small cell lung cancer. They were randomized to receive, now this is interesting, alectinib versus chemotherapy. So that's a little different than the ADORA trial. And I like this because you're comparing specifically the targeted agent to chemotherapy. Do these patients with targeted mutation actually need the adjuvant chemotherapy? I mean, up until the ADORA didn't answer that question, right? So, I still leave it up to the patients. But here, there's pretty good indication in terms of disease-free survival that you can just give alectinib alone and you're going to have a superior outcome than if you're giving the chemotherapy. Now, whether or not chemotherapy and alectinib are better, we can't answer that from here. But at least head-to-head in terms of chemotherapy and alectinib, this makes the argument that you could give alectinib up front. I think this will probably be approved in the coming year. But if you feel like you've been, or I oftentimes feel like I'm banging my head against the wall with these studies, it's just durvalumab in here or pembro in here and nivolumab, they're all the same. What am I going to do with 5 indications in the same space, right? You're not alone. I think, I get it that the companies need to develop these backbones so that they can go on and do the really important studies, which are the novel therapeutics. So going in new directions. Before I get to the new directions, I'll just stop and talk about the new classification that the IASLC is talking about in terms of staging for lung cancers. And this is really to help reduce the gray area that we see with determining resectability, right? So the thought is that if we split the N2, which is usually where there's discussion, right? If you have those mediastinal lymph node involvement, surgeons, they get a little weird about surgery in that setting. But if you start to divide them into a single station N2 versus a multiple station N2, I think that's going to help potentially with understanding who might be more resectable. Those single station N2s are probably more resectable than the multi-station N2s. So hopefully that's going to help some of the staging. Now let's talk about the novel combinations just real quickly. I think there are a couple that I just want to highlight. There's a whole lot more than this, but I think, you know, it's interesting. Regeneron has a study that they're getting up and running in the perioperative space, combining fianlimab, which is anti-LAG-3, with cemiplimab and chemo. We're going to have that study actually open at UIC, so I'm excited about that. That's a new combination. People are thinking outside the box here. How do we, again, it's, you know, the Gordon Ramsay, not good enough. You know, how do we improve more, right? And then the NeoCo study is really an interesting study to me because there's a lot of interesting biology here. There's an anti-CD73, NKG2A, an antisense oligonucleotide inhibitor of STAT3. These are all very interesting up-and-coming targets for the tumor microenvironment. And I think if we're truly going to improve treatment in the perioperative setting, it's going to be about the tumor microenvironment. We use perioperative, and why that's so important is because we know that the tumor microenvironment that the tumor exists in is central to neoadjuvant treatment. That's why neoadjuvant treatment exists, right? And also, potentially, if you have leftover after the surgery, right? Once you just remove a cancer, you change the immune system. So by doing perioperative treatment, you're kind of treating the immune system from the beginning. And so I think that these agents here are going, hopefully, to also help with the remodeling of that tumor microenvironment so that we get better responses in the perioperative space. Okay, here's just the early landscape. Again, I'll put that up for you. I think I went over, so I apologize, and I will end there. Okay, thank you very much.
Thank you, Dr. Thank you, Dr. Weinberg. That was a really great talk about a part of lung cancer that's just changing rapidly. I'll open up to the floor if there's any questions in the audience. Do we have any online questions? One question that I had is, you know, as we do more molecular testing on more folks, especially in the early stage setting, there's a distinction, right? In Checkmate 816, they excluded patients with EGFR and ALK. In Keynote 671, they allowed EGFR and ALK. As we find more patients in the early stage who are having not just EGFR and ALK, but also ROS1, BRAF, how will you approach those patients in terms of whether or not to give them neoadjuvant immunotherapy or not?
That's a great question. And I think we have to be careful because something I didn't talk about when I was talking about molecular testing is the importance of detecting these, you know, targeted mutations for a different reason, for a reason as to why not to give something. So we know that EGFR, for example, if you give immunotherapy before you give the osimertinib, you increase the rates of pneumonitis. Up to 30% of patients will have pneumonitis. So that's a significant issue, right? And so, and it's also hard to really garner whether or not EGFR, and I would venture to say probably the other targeted, maybe not BRAF is special, but certainly ALK and ROS1, whether or not the addition of immunotherapy to an already potentially cold tumor is really doing anything. So I think molecular testing on multiple levels can help inform sort of the art of oncology as we make decisions about how we should actually approach treatment to these folks. But right now, I think we have to remember that pneumonitis is a real thing. You know, it's been reported. we know that you don't want to use immunotherapy before your osimertinib, and we don't know who's going to need osimertinib or not in the early stage setting per se, right? So I have not integrated neoadjuvant perioperative treatment into patients with targeted mutations as of right now.
Great. All right. Thank you so much.
Yep. Yeah.
Okay. It's weird to see yourself on a big screen like this. Okay, perfect. All right, well, thanks everyone for sticking around till the end. Thank you so much to Dr. Weinberg for a great talk thinking about the perioperative treatment of non-small cell lung cancer. I'm going to end today talking also about molecular treatments and how those biomarkers are shaping our treatments in the stage 4 setting. As most of you know, I'm Ryan Nguyen, I'm the assistant professor here. One other thing I do want to mention is also lead our Precision Oncology Tumor Board program. So this is an effort that's led by Dr. Weinberg, Dr. Nafik, who's here in the audience as well. It's a really fantastic program where we're systematically reviewing patients' genomic tests, especially for those patients with advanced cancers who have run out of all other standard lines of options. And so we are accepting external referrals from the community. We have already reviewed cases from the community, and we've impacted people's care at other sites already. So I think as we move forward, we're going to start to see more and more treatments that are more molecularly targeted and not just histology based. So that's my plug I'll make for that. My disclosures, I am on the Speakers Bureau for Merck. I did some consulting for Novartis, and then it should be the other way around. Exelixis funds a clinical trial that I run, which I'll talk a little bit about, but none of these disclosures will impact any of the content that I'm talking about today. So I'm going to talk about 4 things today. We'll talk about all the updates in terms of the FDA with new approvals in the treatment of advanced non-small cell lung cancer with biomarkers. We'll talk about, and then also 3 recent updates to the NCCN guidelines based on major clinical trials which have come out in the past year, the Papillon, FLAURA2, and the Pharos trial. So we'll start with the case. We've got a 62-year-old gentleman. He presents to hospital with shortness of breath. He's found to have a right upper lobe mass, mediastinal lymphadenopathy, a left adrenal lesion, as well as 3 sub-centimeter brain lesions. Biopsy of that right upper lung mass shows, biopsy of the right upper lung mass shows lung adenocarcinoma. We see his PD-L1 markers or immunotherapy markers, which don't show much of a response to immunotherapy. However, on NGS, we are seeing that his tumor does have an EGFR exon 19 deletion, which is one of the classical EGFR mutations. And this is where I will get on the soapbox that Dr. Weinberg put down and step on the same one and talk about molecular testing in non-small cell lung cancer. And I think part of the reason that you see that discrepancy, you see that patients are getting treatment without molecular testing is because the recommendations are not uniform. When you go on NCCN and you look at the actual recommendations, there's a category 1 recommendation in non-squamous for EGFR and ALK, and then category 2A for the rest of these actual mutations. And then in squamous, it's all category 2A. The fact that these aren't all category 1 recommendations, especially for non-squamous, kind of blows my mind away. And I think that discrepancy is leading to the differences that we're seeing in testing. The other thing that you'll see, and it's down at the bottom of the NCCN guidelines in small italics, is that all testing should be conducted as part of a broad molecular profile. And I'll say here at UIC, we have both an internal panel as well as external vendors that we use, and they're all large genomic panels that encompass at least 50, if not more than 100 genes. And I think that really should become the standard of care now. In terms of trying to optimize, making sure that you're getting those molecular tests, there's a couple of things that we keep in mind here as part of our best practices at UIC. And so one thing is that we always do NGS with both DNA as well as RNA-based testing. And I'll give you an example. I had a gentleman who we did we did molecular testing on his tumor. The DNA came back and it was negative. And so I saw him right after the DNA test came back. I told him, we have no molecular testing. We're going to do chemoimmunotherapy. And then 2 days later, I got a notification that his RNA testing came back, and the RNA testing found an EML4 ALK fusion. And we do know that these DNA-based testings don't always capture these fusion events. And so that patient, instead of getting chemoimmunotherapy, was starting on alectinib, and has now had a near complete response with alectinib in a chemotherapy-free regimen, and is living quality of life-wise a much better quality of life than he would if he would have done chemoimmunotherapy. So that's why I'm such a huge advocate for DNA and RNA-based testing. We talk to our proceduralists all the time, so both our pulmonologists, our interventional radiologists, that we need more tissue in order to do molecular testing. This QNS, or quality not sufficient, it leads to delays in care. So even though you're getting the diagnosis, if you don't have the molecular tests, it would almost be like if Dr. Gotti was seeing a patient with breast cancer and they didn't have HER2 or hormone receptor positive testing. It's just an incomplete diagnosis. And I don't think any breast oncologist would ever treat a patient without those biomarkers. And I think it should be the same way in lung cancer now. This is not, I'd say, in NCCN guidelines yet, but I think is becoming part of our practice here at UIC to send concurrent liquid-based testing at the same time that you're doing tissue-based testing. And I'll give you an example. Just a couple of weeks ago, I had a patient who was admitted to the hospital, widespread metastatic lung cancer. We did a liquid biopsy at the same time that he got his tissue. And the liquid biopsy resulted with an EGFR exon 19 deletion within 1 week. So by the time I actually got the tissue back and then the tissue had NGS done, that was 2 weeks later. So I actually was able to start this patient on osimertinib before his tissue-based testing even came back because I did the liquid at the same time. And so this is all about, I think, time is of the essence, especially in the stage 4 setting. So these are all different kind of strategies that we use to try to optimize our diagnostic yield as well as the speed. And then finally, a big thing is as we do more molecular testing, it's also important to think about the financial implications. And so I know that myself, Dr. Weinberg, the rest of our team here, we think about financial assistance a lot. And I think about if one of my patients were to get a large out-of-pocket bill for getting any of this testing done, that would probably force us to stop using that company or that service, to be honest, just because it's not a financial strain that we want to put on our patients to essentially get standard of care. So this is a kind of graphic that I made to think about the current landscape of targeted therapies in advanced non-small cell lung cancer. And so I try to bracket it up into here are the different mutations, and then here are how the NCCN right now, in terms of what are the preferred recommendations on how to treat it. And so you've got your first-line targeted monotherapies, you've got combination targeted therapies plus chemotherapy, as well as second-line targeted monotherapy. And so this is a graph that I made specifically for this presentation, and I'm hoping as my career goes on, we're going to add more things, we're going to move things around. So I'm very interested to see how this graph changes in the next 5 to 10 years. And it's a rapidly changing landscape, right? So you look at all these FDA approvals in non-small cell lung cancer. This is just from 2021. There's been over 8 approvals in the targeted therapy space for lung cancer alone. The one caveat I'll make here is that mobocertinib, which had approval in September of 2021, was voluntarily withdrawn by its manufacturer in the past year due to some recent data that didn't show that PFS benefit in the initial studies. And it's moving so quick that this graph that I found online from a research article was already missing 5 or 6 things, because by the time this graph was made, and this was published, I think, a year or 2 ago, there's a large number of approvals that came out right after that. So I am not envious of whichever student or resident is putting these graphs together just for them to be obsolete within a year. So I'm going to go through a couple selected updates in the first line treatment of advanced non-small cell lung cancer with biomarkers. I'll say we can't obviously cover them all. We've got limited amount of time. So I'm going to focus on the three that have really kind of shaped the latest updates in the NCCN guidelines. So we'll go back to that first patient I was talking about. He has quite a bit of disease. He's got small brain mets that are asymptomatic. And on top of that, he has this EGFR exon 19 deletion. And so when we go back to the strata, you see that for EGFR exon 19 deletions, also for these EGFR exon 21L858R, these are what we call our classical EGFR mutations. At this time, first-line targeted monotherapy with a pill called osimertinib remains to be the standard of care. However, there was a really interesting study which came out in the last year called the FLORA-2 study, which is trying to look at, is that still the standard of care, or is there a new paradigm that we should think about? So in this study, what they did was they took treatment-naive metastatic non-small cell lung cancer. They had one of those two classical EGFR mutations, and they randomized them to either OC alone, which is that bottom bar, which is the standard of care now, which has a median overall survival of over 3 years, or they randomized them to OC plus platinum plus pemetrexed. So you got osimertinib versus osimertinib plus chemotherapy. And then the maintenance arm, after they got 4 cycles of combination, they would then get OC plus pemetrexed in maintenance. This is a fairly large clinical trial. So phase 3, 557 patients, and the primary endpoint for this trial was progression-free survival. And what they found was that combination, you see in orange here, this is the combination. So orange is OC plus chemo and blue is osimertinib itself. You'll see that the median progression-free survival, so how long are these patients living without their disease getting worse, in the combination arm was 25 months versus 16.5 months in the osimertinib arm, with a hazard ratio of about 0.62. So that's a fairly sizable progression-free survival benefit. So if you only looked at this and you only looked at PFS, you would say, this is the new standard of care. This is how we should treat everyone with EGFR mutated advanced non-small cell lung cancer. When you look a little bit deeper as well, when you look at the patients who have CNS mets at baseline, and actually 42% of these patients who are in this clinical trial had some form of CNS mets at baseline, you'll see that this PFS benefit was even more pronounced. So combination, again in orange, is 24, 25 months median PFS compared to just 14 months with the osimertinib arm. So just looking again at PFS numbers, it looks like this is great and this should be the new standard of care, right? But obviously the way I'm phrasing it, it's not the case. So why is that? Just looking through the forest plot, you're looking at all the different subgroups here and you're seeing it's pretty much a uniform benefit for the combination, regardless of the different demographics here. And when we look at other efficacy and safety, this is why it really hasn't become the standard of care and hasn't changed the NCCN guidelines or how we practice right now. So looking at the overall response rate, so that's how many tumors are actually getting smaller. It's 83 versus 76%, so higher in the combination arm. However, once you start getting to median overall survival, the NR means not reached. And so it's still at an interim analysis. Again, these patients with OC alone live at least 3 years, if not longer. So it's going to take a while to see that final overall survival. But you'll see that the hazard ratio is 0.9 and it crosses the 1 threshold. So right now, there's really not a statistical difference in overall survival. And when you look at safety data, the amount of patients that are having grade 3 or worse AEs or adverse events is going to be much higher, 64% versus 27% with your combination versus just OC. And treatment-related adverse events is almost 5 times as much, 53% versus 11%. So yes, these patients are having a slightly longer, or they are having a longer progression-free survival, but they're having much more toxicity during that timeline. And we don't actually know that these patients at the end of the day are actually living longer. And so are we just introducing more toxicity at the beginning of their treatment when they would have gotten chemotherapy upon progression anyways? Whereas the whole point of doing osimertinib and doing these targeted therapies is to spare folks that kind of toxic profile of chemotherapy when they have targeted therapy. So Does FLAURA2 change the first-line management of EGFR mutated advanced non-small cell lung cancer? I would say the PFS benefit is very impressive, but that quadrupling, if not 5 times of toxicity without a median overall survival benefit, that I think has led the NCCN to not include this as the first-line preferred standard of care for these patients. I think right now we're especially the lack of overall survival data is that's not what's pushing us over. But this is under the priority review by the FDA as a new indication. And one thing I'll say is when you look at last year's ASCO, there was another study that did something like this called the AGAIN study. So instead of doing that chemo combination in the beginning, they actually kind of interspersed chemo throughout the osimertinib course. And what they found was those patients actually didn't have any overall survival benefit. So again, I think that toxicity profile you're exposing patients to without an overall survival benefit, this hasn't changed my practice. And I just had a patient who I was thinking about doing this for a couple of weeks ago, but because of that lack of overall survival benefit and toxicity, we chose not to. And when you look at the NCCN guidelines, you'll see that osimertinib continues to be the preferred agent, but it is showing that you have that combination as another other recommended as something to consider. So move on to case 2. So this is a similar patient, has metastatic disease, gets biopsied. We're seeing that the PD-L1 or the immunotherapy markers are a little bit more favorable now. But we're seeing that instead of having that classical EGFR exon mutation, we're now seeing this patient has an EGFR exon 20 mutation. And this is where I think the devil is really in the details, and part of the reason we run this molecular tumor board program is that not all of these EGFR mutations are the same. And something that sticks out to me is when I was in fellowship, we had a patient who came from another hospital, was told they had an EGFR mutation with advanced non-small cell lung cancer, and they had a bottle of osimertinib with them. And when we dug a little bit more deeper, we all assumed, right, this patient has an EGFR, a classic mutation. But once we dug a little bit deeper and finally got the outside records, this patient actually had an exon 20 mutation. And what we know is that these patients who have exon 20 mutations don't respond as well to osimertinib. If anything, they have more resistance. And so that's why it's very important to kind of find the exact type of mutations when this is done. And so looking at this kind of schema again, you'll see that instead of being in that targeted monotherapy group, we now have this combination of EGFR exon 20 in the targeted therapy plus chemotherapy combination. And this is based on the Papillon study, which came out in the past year and has also been a new update to the NCCN guidelines within the past couple of months as well. So it's similar somewhat to the FLAURA2 study in that they took these treatment-naive metastatic non-small cell lung cancer patients, except these patients had to have an EGFR exon 20, so not a classical EGFR mutation. And they're randomized to either get carboplatin plus pemetrexed or carboplatin pemetrexed plus a new agent called amivantamab, which is a targeted therapy, but not like the other targeted therapies. It's actually an IV infusion agent. And so it's an agent that's a bispecific, and so it hits both EGFR as well as the MET receptors. And what they did was these patients were randomized 1-to-1 to both of these arms. And it's kind of similar. It's a large phase 3 trial, over 500 patients. And this trial was looking at the primary endpoint of progression-free survival as well. And in blue, we have got the group that's the combination. So blue is amivantamab plus chemotherapy, whereas gray is just the group with chemotherapy. And this is the progression-free survival. And we're seeing that the progression-free survival is 11.4 months with a combination versus 6.5 months with chemotherapy, with a hazard ratio about 0.4. And what we're seeing is these patients typically don't respond as well to targeted therapy as you would with osimertinib. So with osimertinib, we're seeing a progression-free survival about 1.5 years, but even with kind of this combination therapy for EGFR exon 20, it's only about 11.5 months or so. But I'd say this is a pretty favorable benefit in terms of the PFS. When you look at overall survival as well, you also see that the median overall survival favors the combination. So the combination at this point is not evaluable versus 24 months with chemotherapy. However, that hazard ratio is 0.67. And so somewhat nicely, you know, those patients are still kind of living a bit longer. And so hopefully in a couple more updates, we'll see what that final overall survival looks like. But for now, there is a statistically significant overall survival benefit, which is different than the last FLAURA2 study that we saw. Other kind of key notes here is the overall response rate is much higher, so 73% with a combination versus 47% on its own. And the 24-month overall survival is also much higher, 72 versus 54%. When we talk about combination therapy, you're always got to think about that toxicity profile. And so when you combine amivantamab, you're going to have a higher grade 3 adverse event rate. So it's 75 versus 54%. So certainly a high number of grade 3 adverse events. And specific ones for amivantamab, especially because a lot of us don't have that much experience with it, you're thinking about rash, infusion reactions are a big one, parenchyma, and then also higher rate of neutropenia versus the group that had just chemotherapy. One thing about amivantamab is that it's a targeted therapy, but it's not like these other targeted therapies that are oral agents. It is an infusion, and so it's a 1,400 milligram infusion that's split weekly over 4 weeks, with the first infusion split over 2 days. After that, at least in this combination in Papillon at cycle 3, then they started doing it once every Q3 weeks, so it mirrored the rest of the chemotherapy dosing. I do want to make a note is that this is different than the second line FDA approval. So in the second line setting, where you're just using amivantamab by itself, it's actually given every 2 weeks instead of as every 3 weeks. So this currently is under the review by the FDA, but hasn't been approved in this exact dosing or this exact indication quite yet. So the same question that we asked for the first one, does this change the standard of care? I think the marked PFS benefit as well as the overall survival benefit show us that I think for this population, this is the new standard of care. Although we do have to certainly think about that additional toxicity, and 75% grade 3 adverse events is certainly not anything to just kind of blow over. That's a lot of grade 3 adverse events. One question right now is what's the comparison arm in this trial was just chemotherapy by itself. There's a lot of questions about how do these patients with EGFR exon 20 mutations do with chemoimmunotherapy. And so this trial didn't answer that question of chemo IO versus chemo plus avantanab. But because of the PFS and the overall survival benefit, you are seeing that in the NCCN guidelines for patients who have an EGFR exon 20 insertion mutation, this has now become the preferred option for these patients in the guidelines. And so this is an update that was made just in the past couple months. And so I'll end with one more case. I think we're good. Last case, so this is a 70-year-old man presents to the hospital with shortness of breath. He's also found to have a right pleural effusion and bilateral pulmonary nodules. He undergoes a thoracentesis, and this comes back as lung adenocarcinoma. His PD-L1 markers are actually quite high. He has a PD-L1 TPS of 60%. And the NGS also shows a BRAF V600E mutation. And one thing of note is that we've noticed that a lot of these patients who have these BRAF mutations are presenting with kind of pleural effusion or ascites compared to some of the other mutations. And so going back to our schema, this is actually the only one that sits by itself when it uses targeted therapy in combination with another targeted therapy. And so last year, this is just a couple months ago, the FDA approved a new targeted therapy in this space. So it used to always be dabrafenib and trametinib. And as someone who takes care of folks with melanoma, that's a very common BRAF plus MEK inhibition combination that I use in the melanoma space. However, our good friends in the colorectal space have had a new approval based on this. When I was in Dr. Jane's clinic, this actually came out, encorafenib. For patients who had BRAF mutated colorectal cancer, this combination actually came out as FDA approved, I think in the first or second line setting now too. But what they tested in this study called the FARO study was instead of these patients getting that standard dabrafenib trametinib, now they wanted to try this new combination of encorafenib and binimetinib instead, although both of them are still hitting that BRAF and MEK pathway. And so this is a single-arm phase 2 study, much smaller than the other studies we've been looking at. These are patients who are both treatment naive as well as previously treated metastatic non-small cell lung cancer who had some type of BRAF mutation. The caveat is that those previously treated patients couldn't have had previous BRAF therapy, so they're BRAF naive. And they're all enrolled to get encorafenib plus binimetinib. And their primary endpoint was overall response rate. And you'll see that the overall response rate in the treatment naive was 75% compared to 46% in the patients who were previously treated. And so this kind of goes back to what we were talking about in the beginning, that I think, again, all these patients who have molecular targeted therapies should be tested upfront to ensure that they have all their options, especially for targeted therapy in the first-line setting. But you are seeing in this waterfall plot quite a bit of deep, pronounced responses with the targeted therapy. Looking again at the progression-free survival, at the top, we have the patients who are treatment naive versus in the bottom, those who got previously treated. And you're seeing that it's 18.12 months median progression-free survival versus 12 months with those who are previously treated. And at this time, overall survival is not evaluable for both groups. Looking at grade 3 treatment-related adverse events, you're going to see that that rate is about 41%, with the major treatment-related adverse events being related to nausea, diarrhea, fatigue, and vomiting, which are fairly common side effects that I've seen with folks who've been on the dabrafenib-trametinib combination. And so, again, it's always hard to do these cross-trial comparisons, but unfortunately, when the trial is designed to not have a comparator, this is the only way we can actually compare them. So what I tried to do is try to look at the actual data between these two. So we've got our new approval, encorafenib plus binimetinib on the right, and the standard of care previously, which is dabrafenib and trametinib on the left. And you'll see that the overall response rates in the treatment naive are fairly similar, although it is higher in the FARO study. In those who are previously treated, it's actually higher in the dabrafenib trametinib arm. The median overall survival and the median progression-free survival were not evaluable for the FAROS arm. Excuse me, that is a mistake. The median progression-free survival was about 18 months in the new FAROS study. But one thing I wanted to point out is that it's very hard to compare the actual side effect profile, because when you look at the FAROS study, they only looked at what we call treatment-related adverse events. So those are adverse events that they specify are related to the actual treatment itself, which they put at 41% for grade 3 or worse. Whereas in the dabrafenib study, they listed grade 3 or worse adverse events, but these are all adverse events, so those that don't always include treatment, and that's at 69%. So when you try to compare the two, it's going to look like this new combination has less side effects, but unfortunately, both studies don't include a direct comparison with the other, so it's hard to say if it really has less side effects or not. So what is the standard of care for these patients? Unfortunately, at this time, there's no head-to-head data. It's very hard to tell which one is better. The lack of overall survival data, long-term overall survival data, I think is what's holding back a lot of folks from making the switch completely to encorafenib plus binimetinib. It potentially has lower toxicity again, but we don't know the direct comparison. So at this time, when you look at the NCCN guidelines, it's actually preferred to do either of them. I think because a lot of us have experience with dabrafenib and trametinib, and we have that overall survival, it continues to be a familiar option for a lot of folks. We know how to manage that toxicity as well. But I'd like to see in a couple of years, what that overall survival data looks like with this new combination. And with that, I'm going to finish off with a couple. I just want to go over our lung cancer trial portfolio here at UIC. We have quite a bit of trials which are opening up in the future as well, but just want to highlight that they are all biomarker specific. And so I think that's where we're going in this lung cancer field. A lot of the trials are going to be biomarker specific. So we have a trial for patients who have EGFR that includes OC plus bevacizumab. Lung IST is a trial for patients who have squamous cell lung cancer, which is a highly underrepresented group in the lung cancer trial population. And this is an IST that I actually did when I was a fellow and now as the PI here, where we do cabozantinib plus pembro in the maintenance setting. We have a PD-L1 negative trial where we combine immunotherapy plus SBRT. That's an alliance trial. And then finally, for those who are PD-L1 positive, we also have a Keynote B36, which is a tumor treating field, which is a kind of device that people wear in addition to pembrolizumab to see if there's any synergistic effect there. So we have quite a robust clinical trial portfolio, and we have more trials that are coming pretty soon. And with that, I will stop and go for any questions. Thank you.
That was great, Ryan. I so my question has to do with those combination uh trials with the chemotherapy and the targeted agent.
Mm.
I think, and I just got done during my talk saying that we overtreat and that's okay. But what I was talking about was in the curative setting, right? Here, we're not talking about patients who are technically being cured of their disease and they're getting these toxicities from the combination treatments. So I wonder, uh, you know, is the combination treatment, is that something that we need to be doing? What's to say that we couldn't treat with osimertinib and then on progression add chemotherapy to that? I don't think people have looked. I don't know, if somebody has kind of looked at that, but I think back to like first generation, second generation TKIs and how we used to treat EGFR, and people would put together these, like, they would add studies, overall survivals together. And I just wonder if, the combination arms are equivalent to basically treating with osimertinib and then adding the chemotherapy, or vice versa per se. I just think, again, that biomarker, we need better biomarkers in this spot, especially in the metastatic setting, so that we aren't overtreating patients who really the goal of cure is not with these patients, it's palliation, right? We forget that in the field now that we have such great tools to use. So I guess my question really stands on what's to say, that these trials, even if they are FDA approved, are you going to actually integrate that into your practice? I don't know. I mean, I kind of still feel like might do osimertinib and add the chemotherapy unless we know for certain that that's not benefiting patients. So
Yeah, I completely agree. I think about the handful of patients that I have on osimertinib right now, and I think about the quality of life that they have compared to my other patients who've got stage 4 non-small cell lung cancer, who they don't have to be on chemotherapy. Now they're seeing me maybe every 2 to 3 months if they're very stable. They've had a great response to therapy. They're able to do all the other things that they want to do with their lives. And I think about if I had started them on chemotherapy at the same time, and now have to continue them on this chemotherapy that whole time, only for maybe at the end of the day for them to have the same overall survival if I would have just waited. And so I don't know if quality of life was included in those studies, but certainly I see it every day. These patients who are on targeted therapy, going on vacations, living their normal lives. And that's something that I certainly don't want to take away from any of my patients, especially in the stage 4 setting when I know that a cure, at least at this point, isn't possible. Yeah, yeah, mhm, yeah, yeah. Yeah. It- Yeah, and that's why, you look at there's a trial at ASCO I had mentioned called Again, where they kind of intersperse chemotherapy instead of putting at the beginning. And I understand the scientific rationale, right? You're trying to kill all those EGFR resistant clones up front before they become a problem. But unfortunately, I think all these different trials which have tried chemo at all these different points for these patients, none of them have shown an overall survival benefit quite yet. And I think it's because at some point these patients are going to see chemotherapy, but why kind of put them through that toxicity in the beginning if it's not actually going to make them live longer? And again, I think you're robbing those patients of that kind of last chance they have at quality of life. One second, I just want to make sure everyone can hear. Yeah.
Oh, perfect. Thank you. Yeah, I think that makes a lot of sense when we think about the first line and OC up front in the FLAURA2 trial with the classical EGFR mutations. But then, as you noted in the Papillon trial, when previously chemo monotherapy was that first line and then second line was AMI, then when those were combined, we did start to see trends in things like OS. So I'm curious, is there something about sort of the classical EGFRs versus maybe an uncommon one like exon 20 insertion that you think is maybe differentiating some of those results that we're seeing instead of sequencing, but actually combining them up front and seeing the better results?
Yeah, I think with things like classical EGFR, ALK mutations, we know that they respond so well to therapy. And I think I'd have to look again, but I think amivantamab just by itself in the first line setting doesn't have that same kind of overall response rate that you're seeing with osimertinib or with alectinib. So I think it's probably just not as much of a driver as it is as with those classical mutations. And so, I mean, I'll say one thing I think a lot about amivantamab is that it's also not a pill. It also doesn't have that same kind of quality of life benefit that you would get with a pill. You have that kind of infusion reaction. You have to do kind of split dose dosing. It's actually more inconvenient from like an infusion standpoint. And so these are all different things that kind of come into my head when I'm thinking about a patient and their quality of life. And so, that grade 3 toxicity that you see with that combination, that certainly is kind of worrying, but certainly that PFS and OS benefit I think is there. And I think it's kind of a shared decision making with the patient about whether or not to do that combination up front. Okay, thank you so much.
We're just going to have some closing slides for you, Ryan.
Okay, perfect. So thank you so much to everyone for being part of the very first day of the very first iteration of this UIC CME event. We do have 2 more events that are coming up both next Wednesday and the Wednesday after that. Next week, we've got women's health, and then the week after that is hematology. So I know a lot of work has been put into that. I want to thank all of our speakers today, especially for taking their time and their expertise to be part of this, all of our sponsors, and then of course, all the registries, all the participants who came here to learn to be a part of this. I think we go to the next slide. I covered all of this already. To get your CME, you do have to do a post test, which I think we might have a QR code.
The next slide.
Oh, it's the next slide. Okay. To get your CME credit, please scan this so that you can take your post test and make sure that you can claim your credit. I'll get everyone a chance to scan.
And we will email this as well to the email that you gave when you signed in. But this is also a way to have direct access to the site.
Okay. And I think, oh, and last thing for all the folks who are here, we are going to do this again in the summer. So it'll be much nicer then. It won't be as cold. We're going to do it in the same venue in June. So it'll be June 12th and June 19th. At that time, we're going to be going over ASCO updates. So I'm hoping that that diagram that I put together will look totally different in 6 months from now. Hopefully at least 1 or 2 changes. And I'm sure we'll have a lot of our kind of great speakers that are here today at that as well. So thank you again, everybody. One last thing, I also want to shout out our AV help. Thank you so much for coordinating today. Yeah. And then Nicole, as well as the rest of our kind of coordinating team who have been working tirelessly to put this event together. So thank you so much.
Thanks.
Thank you, everyone.